I'm joined as a moderator by the unforgettable Dr. Glenn T. Pate, who joins us as Professor of Neurosurgery at UAMS, and he'll be joining us as a moderator in talking about this very interesting topic. And the topic for tonight is avoidance of the pitfalls and management of esophageal injury following anterior cervical spine surgery. I'll do a brief introduction and then I'll be joined by Dr. Ryan Turner, who is our third-year resident here at the University of Arkansas for Medical Sciences, who will present a couple of cases and some salient points derived from those cases. And then Dr. Matthew Helton, our senior resident, will discuss both the literature search on the topic, on this very important topic, as well as a synopsis of a paper recently published from our institution describing our experience with this very important complication. So I'd like to share my screen with you at this point and go ahead and hopefully you can see that. And hopefully again, this is visible.
It is, but we're seeing your preview slides, Dr. Kazemi.
Right. Is this better?
Yeah, that's better.
Okay, great. Thank you very much. Thank you very much for your patience. So pharyngoesophageal complications, as we refer them here in these slide series as PEP complications following anterior cervical surgery, are obviously a rare but very devastating complication following ACS surgery, which of course includes ACDFs, one of the most common procedures in spine surgery, cervical corpectomies, and cervical correction, anterior cervical correction surgeries. And it is obvious why, but just to reiterate some of the impact on them, of course, they often lead to these very prolonged hospital stays where the patient's nutritional status is altered. They're kept fasting for prolonged periods of time. They require enteral feeds, such as through gastrostomies and so on. And of course, they represent a wide range of symptoms, which we'll discuss in a second, but a major part of which is infection that can result, and this can be devastating, leading to sepsis and even death. Thankfully, as I mentioned, the incidence of them is very low, and they really range up to 1.5%, with an average of about 1 in 50 cases following anterior cervical surgery. And that in itself does appear a little high, but that's what the data and the literature bear out. And they seem to follow most commonly traumatic presentations for anterior cervical surgery. And this again is perhaps not surprising to understand, given the risk that trauma presents, both with something like, let's say, bilateral facet fracture dislocation, where there is mobility or movement of one vertebrae over another, and necessarily mobility and adjustment of the retropharyngeal structures. But of course, we also see that in degenerative disc conditions, disc herniations, even disc replacements, and so on. And trauma isn't just a method of injury because of direct injury to the vertebrae itself, but also a hardware, of course, is utilized, and that in itself may be under stress. And when the hardware fails, typically it fails ventrally, and of course, what's in front are the ventral structures, the pharyngeal space, the retropharyngeal space, and of course, the esophagus, both through direct bony impact, but also through hyperextension of both the vertebrae as well as the instrumentation themselves. So very brief anatomy. This really isn't the focus of this talk. I'm hoping we will be joined by Dr. Sunday, one of our ENT surgeons, shortly. Apologies that he could not attend immediately. But the classic spot for injury to the esophagus is known through this Killian's triangle, which is this triangle here. You may see it separated by the structures of the constrictor muscles, in particular the thyropharyngeus, and then the cricopharyngeus, which spans mediolaterally. There is this defect here where there isn't a muscular layer, and there's only this buccopharyngeal fascia, which separates the esophageal mucosa and the vertebrae. And the other area of weakness are these lateral walls of the piriform sinus, as depicted in this posterior drawing here as well. You can see the piriform sinus in this kind of striated region here, and there's the lateral wall there. Again, there's a defect there in the muscular layer, and hence the mucosa is more prone, suspect to injury. So what about the presentation? Well, this is kind of the interesting part to it, because the presentation is so variable. Patients can present from neck abscess to hardware dislodgement to no symptoms at all. And that's why it's easy to overlook these symptoms. Typically, early on, when esophageal injury is not suspected. So where we want to examine dysphagia and other symptoms, we have to raise our index of suspicion for an injury. And these patients present with neck pain. They present with painful swallowing and eating. They present with fever. They present with surgical site swelling and drainage, particularly in the early presentation of these symptoms. And that was what we found both in our series as well as in the literature. And again, like I said, patients can be asymptomatic, and it may just be detected during regular follow-up of these patients. So here's a few important points that I want to stress. These patients can present during your operation, whereas there's clear iatrogenic injury to the esophagus. They can present in the early phase, or they can present many, many years later. And it's something that we need to kind of experienced spine surgeons can attest to this. But those of us who haven't had the length of time, for example, to cover this late presentation, need to keep that in the back of our mind, particularly when we inherit patients from other practices and other surgeons. Among those who present early, the intraoperative injury component is really a very small presentation. If you clearly have injury from damage to the by the burr, the Midas Rex drill, or whatever it is that you use, well, that's obvious, particularly when you feel that there's mucosal injury. But that otherwise the early presentation is really with things such as unexpected fluid being drained through the anterior cervical drain, swelling, infection, difficulty swallowing, and so on. And of course, as we'll see in both the cases and the discussion, improper presentation and placement of hardware is an absolute key risk factor to development of these symptoms. Delayed presentation, which is approximately about 60%, is often due to that erosion by the hardware across the mucosal and muscle layers of the esophagus, leading to this late presentation. We found from the literature that the average presentation was approximately 50 months. And that's interesting because it often exceeds that 12-month period of follow-up that many surgeons may have as an index, as a metric, following an ACDF, for example. And that's why it's important to discuss these symptoms with the patient during the workup, educate them, and have a high risk or low index of suspicion when they present with difficulties such as swallowing and so on. So what about the approach to them? Well, any patient which presents with these symptoms necessitates further follow-up. And obviously they may present very emergently as well. Just the brief synopsis is that you're going to, as a spine surgeon, often want a CT with contrast, both obviously to define the extent of your instrumentation as well as an infection that can be seen. And then you ask your ENT colleagues to help with direct view and laryngoscopy, endoscopy of the structures, particularly to assess important things such as vocal cord function and assist with surgical management. But to go into it in a little bit of detail, X-rays, widening of the retropharyngeal space, subcutaneous emphysema, loose or missing hardware. The esophagram with the barium contrast can easily identify the leak, demonstrate spillage in the prevertebral space or the operative site, and it can also determine the extent of the leak on swallowing and its relationship with the adjacent structures such as the mediastinum, the pharynx, and the larynx, and so on. And of course, they often perform endoscopy to look directly for visualization of the spinal hardware through the esophagus. Important caveat to that is that experience is needed during the air insufflation not to extend the tear even further. So what about management? Well, here's where we end, and I'd like to continue with the other slides. There are no clear guidelines. This is not something that's to date been nailed down by our community with respect to the exact steps needed. Obviously, a major part of it is nutrition management and surgery. But I came across this important article in the Global Spine Journal by Meleta et al., published last year, which provides a very comprehensive algorithm, if you like, consisting of assessing whether there is late or early presentation, the size of the injury or perforation, and often there is a follow-through through the right-sided aspect of this algorithm, because most patients cannot be treated conservatively, require surgical approach, such as direct repair where it's possible, but unfortunately most likely requiring either a local flap, a supplement such as a sternomastoid flap or a strap muscle flap, supplemented possibly by another vascularized flap or free flap, such as a mental flap, a radial flap, and so on. And then there is importantly, and this is something that we're going to discuss in the second half of this presentation, what does the spine surgeon need to do? How are they going to tackle stabilization, hardware removal, backing up through a dorsal instrumentation, or assistance with respect to corpectomy and or removal of vertebral structures. And this is a beautiful article looking at this algorithm in detail. Okay, without further ado, I'd like to now invite Dr. Ryan Turner, our resident, to present some cases. And we're joined now by Dr. Yuman Sunday, our expert ENT surgeon at our institution, and his comments will be valuable, as well as the rest of the panel here.
Thanks for having me.
Yeah, thank you, Ryan. Please go ahead.
Yeah, thank you. Good evening, everybody. Share my slides here. So yeah, we're talking about management of esophageal perforation, as Dr. Kazemi said. So I'm going to run through a couple of cases and then talk a little bit about our series here over the last couple of years. So this first one's a 57-year-old female presented with dysphagia, as is common. Her index surgery occurred 6 years prior. She underwent a C3 to 7 ACDF. The indication was degenerative disease. And this patient reported to us having had dysphagia since surgery, essentially, and had altered her diet over the course of those years and included some softer and higher calorie foods in order to avoid weight loss, although she had had some weight loss. She was scoped and tissue erosion was seen, and the anterior cervical plate was evident in the esophageal lumen. I'll show her preoperative imaging here. Just point out a couple of things on this. First one is that the fusion you can see in this cut is really solid. The second is that the plate here is well seated. We don't see any hardware failure or screws backing out or anything. So she was admitted in elective fashion to undergo surgery. Because she was well fused, the anterior cervical hardware was all removed. Our ENT colleagues then resected the posterior wall of the hypopharynx and the cervical esophagus. That resulted in an 11 by 5 centimeter defect, and that was repaired with a fasciocutaneous radial forearm feed flap, and then that was bolstered with an SCM flap as well. The patient did require a PEG tube, but did well. She was able to discharge on post-op day 5 and was tolerating oral intake, and follow-up in post-op day 16 and did quite well. This is just an intraoperative image from that case. You can see the anterior cervical plate here, and the esophageal defect is the esophageal lumen. Next case is a 71-year-old male who presented with dysphagia, initially diagnosed with a Zinker diverticulum. A scope was performed, and again, the anterior cervical plate is visualized in the esophageal lumen. This patient had had a severe weight loss of 100 pounds since his surgery, which was 18 months prior. Involved a C6 corpectomy, fused 5 to 7. He also had a posterior 5-6 fusion. Indication with this was trauma from a motor vehicle accident. So he ended up undergoing removal of the hardware because he was not fused anteriorly. We performed a corpectomy at C5 and extended the fusion. Again, our ENT colleagues repaired the esophagus with this time a vastus free flap, and he also required a posterior extension from 3 to 7. Show his preoperative imaging as well. And he's well fused posteriorly. And the other thing with this patient, as you can see, he has dish, a significant amount of anterior osteophyte there. And the plate here, although it's fairly well seated on the inferior border, you can see that it's seated against the anterior osteophyte as opposed to the vertebral body. Another intraoperative image from his case, again, cervical plate here, fairly large esophageal defect. And here's his postoperative imaging. So we extended the fusion both anteriorly and posteriorly. This patient did quite well postoperatively as well. He was decannulated at 3 months, and by 8 months, he was tolerating a regular oral diet. He was still supplementing by PEG feeds at that time, but had gained back 50 pounds, was not having pain or dysphagia. So this is a table kind of showing our series here over the last several years. I'm going to point out a couple of things. We had a variety of indications for our surgery, trauma and degenerative, and then one tumor. Most of these patients had had more than one anterior neck operation, either a revision or an additional anterior cervical spine surgery, or an anterior cervical or an anterior neck surgery. They almost all presented with dysphagia, and then none of them had only undergone a single level ACDF prior to the esophageal perforation. Some of them, a majority of them in our series, were corpectomies. The other were longer segment anterior cervical fusions. And then hardware back out, which Dr. Kazemi had talked about a little bit, we did not actually see predominantly in our series. There was 2 cases. This one was more prominent, dislodgement of the hardware, but most of the hardware in our series is well seated. And then another potential risk factor is the extent of the anterior osteophytes preoperatively. And again, did not see that in most of our cases. A lot of these did not have any significant anterior osteophytes. There was the one case of dish, and in this case, we just had prominent degenerative osteophytes. That's my last slide there. I'm going to turn it over to Matthew Helton.
Actually, Ryan, could you keep the slide up there?
Oh, sure. Yeah.
It's really important enough to share with the panel and then the audience themselves. You know, this is obviously a very limited series, but I wonder if these results echo the experience of those on the panel. I, for one, was surprised at a few things from our data here. One was that you didn't see this kind of complication following single level ACDF surgery. And I think that perhaps that isn't surprising, that it's a more limited surgery, it's a limited access, there isn't as much retraction by your retractor of choice on the esophageal structures and other visceral structures that we do. So that one perhaps isn't surprising. Again, revision surgery where more than one anterior operation had been performed prior to presentation, I don't think that's surprising at all. I think that the more number of times you enter the anterior cervical space, the prevertebral space, and you open the structures, mobilize things around, you're more likely to both increase obviously the incidence of injury just by being there more, but also to create scar tissue which may tether down the esophagus in parts, including Killian's triangle and so on, and subject it to injury when mobilized. I think for me, the surprising part was that hardware backout represented one source of etiology, but it wasn't the case always. Where there was hardware, and vast majority of these cases, there is hardware. Maybe that's because the vast majority of anterior cervical surgeries are performed well, where the instrumentation is flush, low profile, and we don't have backout or displacement, or maybe that doesn't matter as much as I thought. And then the second thing, of course, is the multiple anterior osteophytes seen in dish or Forester's disease, where you have these mountains and ridges of these huge osteophytes. And I guess that's because this is a chronic condition. Over time, things have developed, but nonetheless, it wasn't because those patients had operation in that setting and then they represented with a tear. I might start with my colleague, Dr. Pate. Dr. Pate, could you share with us your experience and if these findings make sense to you?
Sure. I think there are a couple of points here. I think the surgeon has to be aware that there are traps along the way to get to the spine. I think you have to recognize that you have important neural structures, you have vascular structures, you have respiratory structures you deal with, and intestinal structures, which we're talking about here. So meticulous exposure is very important. The other thing is the choice of the incision. Everybody wants to be smaller nowadays, but you have to tackle the job, and the pathology will demand that you acquaint yourself with it. If you do not appreciate the pathology and the demands of the approach, and you use a wrong approach, you're going to get into trouble. By that I mean, if you want to do a 3-level corpectomy and the incision is horizontal, I'll grant you, I remember Wolf Casper swearing that he could go from top to bottom with an incision in the middle, but the incision was from one side of the head to the other. So I would not recommend it. So the choice of the incision to address the pathology is very important. If you're going to go a 3-level, 2-level corpectomy, you may want to think that the horizontal may not be the way to go, the carotid or the vertical incision, because once you put the retractors in, and you try to reduce them and your exposure isn't good enough, what are you going to do? You're going to battle. And then what caused the mischief here? You know what it's going to be? The greatest mischief maker is a wandering blade. Yes, I know they had a musical about Wandering Blade, didn't they? Paint Your Wagon or something. The original song was Wandering Blade. But it's a little joke. But the wandering blade could get you into trouble. We've all had wandering blades where the doggone blade just won't go under the longest column muscles. So you really have to do, particularly the longer the dissection and the longer the pathology, you've got to underline the longest column muscles. You got to get under there. And then you've got to look at the blades of your retractors. And if you find a great deal of problems with those retractors, you've got to either undermine tissue more or recognize that the incision may not be adequate. So the wrong incision and the choice of the wrong incision is going to get you into trouble, that is going to cause a wandering blade. So you got to be very careful about that. So I'm not surprised with these. We didn't talk about the incision. Most people of the age group you're dealing with, they just want to be better. So the incision's not going to be a major issue for them, as a lot of people will talk about. Single level discectomy, that's a different matter.
Yeah.
But with multiple levels, tumor, primary, particularly myeloma. My God, you never want to make a small incision for myeloma because the bone above and below may not be competent, even though the radiological studies can say, my gosh, that is the best looking bone I've seen in the entire spine. You get in there, the next thing you know, it's incompetent, so you got to go to another level. So you have to know the pathology, the demands placed upon your surgical skills and your ability with pathology. So those are things I think. Choose your incision wisely.
No, thank you very much. So to the salient point about the dissection, the incision, the dissection, and the approach, I'd like to ask Dr. Sunday, our expert ENT colleague at UAMS, can you shed some light with us about this Killian's triangle and any tips for the spine surgeon as to avoid injury during the approach? And the flip side of that question is, when would you think it's appropriate that we call you as our ENT colleague to help us with the approach? I mean, single level ACDF, 2-level ACDF, probably not. But when we're performing multi-level corpectomy and or wide dissection, does it make sense to have our ENT colleague there? It's a little bit of a loaded question, but I'd really love to hear your insights on this. Thank you, Dr. Sunday.
Yeah, thank you. I think really like anything else, I think it really just depends on the comfort of the surgeon and the experience. I think I'm a young guy, so I've only worked with a handful of spine surgeons, but some are very comfortable in doing their own approaches, even in very complicated cases, and they have a high volume and do just fine. And others, as they're starting out, kind of appreciate having backup. And so I know some younger guys who, any revision case or any multi-level case, they'll kind of ask us to be present. And many times in 6 months or so, they kind of get their feet. You don't hear from them as much anymore. So I think it just really depends on the surgeon's comfort in that setting. One of the rules that I use and that I was taught and that I kind of always pass along if I'm doing an exposure with somebody is, the things that get you in trouble, we call it the visceral space, but the space in the central neck that contains the respiratory and the elementary structures, your esophagus, your pharynx, and your airway. Obviously, they're all medial, and the recurrent nerve is there with them. And I think one of the biggest tips to having an approach that avoids these complications is, when you enter the neck, I try to stay on the medial aspect of the carotid, along its entire vertical course, and I try to enter the prevertebral fascia in that vertical plane and not wander medial. And if you practice discipline in really respecting that sagittal plane of the carotid and trying to stay as far lateral as you can when you're entering that fascia, you really don't have to identify the recurrent nerve. And your risk for injury to visceral structures is very low because you're going to get under the longus coli laterally before you ever venture, into the pharyngoesophageal structures. And I think that's the only tip I could probably provide as far as just kind of as a basic tenet and principle, stay lateral, identify your carotid early, depending on your level, ligating middle thyroid veins to mobilize your jug. I ligate the superior thyroid artery if I'm going high, and in a more of a submandibular type approach if I'm going above C3. But irregardless, I think the biggest thing I keep in mind is knowing the sagittal plane of the carotid and kind of keeping that lateral approach.
No, thank you very much. Yeah, I think we all do respect that. Most spine surgeons are definitely aware of that, and we respect that very much. And of course, we work in that plane, and most spine surgeons are very comfortable with that. So that's an excellent tip. Thank you.
I'd like to add a point with these injuries. And we could ask Dr. Sunday what he thinks about this. We divided them up into the upper cervical injury and the lower cervical injury. And I've seen both, and I've directed attention towards both. And I've seen the non-surgical avenues being directed toward an injury of the esophagus in the upper cervical spine. The higher up you go, the longest kind of muscles are no longer quite as protective as they are down below, so you can get into more trouble. And I've seen handling these with what you're saying, people are no longer using that tract to eat with. They're eating parentally. They're on antibiotics. And I've seen that, and people have done well without surgical intervention. The lower injury, without doubt, I think that surgery is the avenue to pursue. In fact, a lot of the thinking now is that if you have an injury to the esophagus, you're going to go surgically with it. But there are those, and previously, and I have seen esophageal injuries in the higher spine treated non-surgically. What are your thoughts from head and neck surgery with that?
Yeah.
Upper cervical,
Yeah, it's a
esophageal
good
injury.
question. A lot of what we do obviously are cancer-related defects, and so the vast majority, because these are relatively rare cases, I think a lot of the experience that I always reflect on for basic principles goes back to the higher volume surgery that I do. But for instance, if we're doing like a maxillectomy and we're making a large mucosal defect that's non-dependent, there's no pooling saliva in that area, even if the patient gets a fistula, the risk of infection is almost nil. So the risk of infection really begins where you start to have dependent salivary pooling. And so, if you have a pharyngeal injury that's high, above like tonsil area or a pharynx more, I think contemplating a conservative approach is more reasonable. I think as soon as you get into the dependent areas in the pharynx, so even hypopharynx and into the cervical esophagus, I think those are going to leak. And they're going to leak significantly. And so I think conservative management, in my opinion, just really prolongs hospitalization for these patients, because with modern reconstructive techniques, 4 or 5 days after surgery, these patients can get out of the hospital. And so, I wouldn't be a big advocate for conservative approaches in those dependent areas.
Right. So I think in any of these, we're called upon a head and neck surgeon just to take a look. I noticed earlier people were talking about barium studies, and they were negative, and I've seen that before. I think there was one case we had a woman like 7 years, and she was cachectic, and she had several studies, and those barium studies are negative. In your experience, how often do you see a negative a study of that nature with an injury to the esophagus?
In an acute injury, I think that would be very unlikely, but I do think in these chronic injuries where, essentially you can almost think of it as like a pressure ulcer of the esophagus. You have a lot of fibrosis, synechia, scarring, and it's a very slowly evolving process over years and years where you finally get this ulcer that basically, results in exposed hardware into the lumen of the esophagus. And I think in those cases, it is much more of a quandary at times. And I think, and I've seen that scenario play out where, you may have to defer to an endoscopy or just an exploration if you have a high enough index of suspicion.
I agree. I think the chronic ones are less likely to show you that the defect. More acute, you're going to see it. But I have seen, in fact, one of our senior head and neck surgeries, Dr. Sun here, and I've been following for years, the overgrowth. And when you look in the esophagus, there's a plate, but he's swallowing just fine. He has no problem. He's refused any surgery. And also, he doesn't have much tissue to close, and he's an elderly individual, but he's doing just fine. He's closed and sealed everything off. He just has a plate that's in the esophagus. Every year he comes back and we take another look. But that's a rare case, though. That's rare.
Yeah, and the hope is that he continues this way. I
Well,
guess
I don't know how to fix him. We really
right.
not sure how to fix him right now. Dr. Sun probably will pass it on, I guess.
Yeah, well, you'll inherit the case.
He's refused. He's absolutely refused surgery. But I think that's the point folks wanted to make. A chronic injury, you're going to seal it off some, and the chances of having a positive study is going to be low with the barium.
Well, it's interesting because I think, we've had situations where the perforation wasn't clinically apparent until after the revision surgery was performed for displaced hardware. So the patient presented with no dysphagia, no symptoms, and then there was displacement, there was a revision surgery, and the hardware was revised and fixed, and there was no hint of an injury intraoperatively, only then for the orange juice to come out through the anterior cervical drain in the recovery. And so, to that point, Dr. Pate, I think that yes, there must be situations where either the mucosa is extremely thinned or held together by the prior hardware, even if it's displaced. And in that situation, what can you do? You deal with it, right? You then deal with it as an injury. but it occurred after the revision was done. Last question for Dr. Sunday, and then we'll move on. If you suspect an injury intraoperatively, for example, through the different pathways of causing an injury that we mentioned, what is a kind of quick method, a reliable method, would you say, for us to kind of identify it? Because we do want to identify it. We'd rather identify it and call you intraoperatively. So what can we do? What do you suggest?
Yeah, that's a great question. The technique that I use, and this is again extrapolated from just doing, pharyngeal reconstructions after, for instance, laryngeal cancer surgery, et cetera, we always test that our closures are watertight. So we leak test in all of those cases. And the way that we do it is just basically a dyed saline solution. And I use a betadine dyed saline solution because it's ubiquitous. Everybody has betadine in the operating room. You can just, splash some betadine and saline, it gets a color. And then you can basically insufflate the lumen of the pharynx and the esophagus with this. And frankly, the biggest pro tip there is do it through the nose. It's hard actually to put something in the mouth and get it to seal. So you actually I use a big basting syringe with a big bulb top on it, like a 50 cc basting syringe, fill it with a solution, put it in the nair. And you can just basically, and I know in your case, this will be outside the sterile field, so you may have to ask an unscrubbed colleague or an anesthesiologist or somebody else to do it, or a resident. But you basically get the basting syringe in the nair, just hold the lips shut, put your hand over the mouth and insufflate. And the person looking in the wound will actually, you can see the lumen start to expand as that solution starts to pressurize the lumen. And if you have a hole, it's going to become readily apparent. You'll just see betadine solution coming into the wound.
So you'll see the solution if there is a perforation, and you'll see the insufflation if there is a muscle tear and the mucosa is stretched. Is that correct?
Correct. Yeah.
Right.
Correct.
Perfect.
And so it's an easy way to, do a quick interrogation on that if you have a suspicion.
Excellent. Thank you so much for that pro tip. That was extremely useful. Hopefully we won't need to use it as spine surgeons, but if we have a suspected case, that's the pro tip. Okay, Dr. Matthew Helton, our senior resident, is going to present the literature. Please go ahead, Matthew. Matthew, you're on mute.
Okay, so I'm going to share some papers that I found useful to review in pharyngoesophageal perforations after anterior cervical spine surgery. I'm a resident here at UAMS. So background, like Dr. Kazemi mentioned earlier, pretty rare complications, 0 to 1.5%, but mortality rate can be as high as 6% in a reported paper. Management is difficult, multidisciplinary, and there's no standard of care. Here's an image of a barium swallow gone bad after a esophageal perforation after spinal surgery. So the first paper I want to talk about today is this paper published in 2016 in JNS, Esophageal Perforation After Anterior Cervical Spine Surgery, a Systematic Review. This paper uses the PRISMA guidelines to include history of anterior cervical spine surgery, esophageal injury, diagnosis during or after surgery without esophageal injury prior to the index spine surgery. Those are the cases that they included, and they used a variety of case reports and case series from the literature. And their goal was to define a rate of esophageal perforation, define the expected patient presentation, the causes of the perforation, the types and numbers of repair that were required to fix these problems, and patient outcomes. So after their PRISMA guideline meta-analysis, they were able to find 65 studies for qualitative and quantitative analysis. The baseline demographics, the patient's age on average was 45 and 53.6% male. The indications for the index surgery were by and large traumatic, which is what Ryan Turner mentioned earlier. Myelopathy was number 2, disc herniation, degenerative disc disease, malignancy, Angst-Bondy, and tuberculosis were also all mentioned. Some patients had multiple indications for surgery. but you can see that trauma was overwhelmingly the indication for the index surgery, resulting in esophageal perforation. And the presenting symptom, half of patients presented with odonophagia, 19% of the patients presented with fever, 18% neck swelling, and 14% wound leakage. And so these are all things we kind of mentioned prior, but once the favorite is odonophagia, followed by concern, but then half of patients presented with symptoms or signs of infection. So looking at the most common levels, which as predicted would be C5-6, just because it's one of the most common levels to be operated on in the anterior cervical spine. C6-7 was number 2. 35 of the patients that in the data that was recorded underwent corpectomy, while 54 were discectomies. And then I thought the time to diagnosis was interesting. So the days since index surgery leading to diagnosis on average was 717 days, but the median was only 45 days. And I think this demonstrates that kind of bimodal peak that we've been talking about. You have your acute perforations and you have your chronic perforations. The acute are most likely a result of an intraoperative error, while the chronic is more of that pressure ulcer Dr. Sunday mentioned. So in the early period, which they defined less than 30 days, they determined that 13 of these cases were intraoperative tools and dissection, a result of intraoperative tools and dissection. 6 were hardware failure, and only 3 were chronic. While in the delayed, they attributed the perforation to 25 at the time, or 25 out of 46 was hardware failure, and 20 chronic erosion of hardware. So, the hardware failure and chronic erosion of hardware, I think, is somewhat similar. The only difference is when they say chronic erosion of hardware, it means that the plate and screws remain well seated. I think hardware failure also causes erosion. It's just that the plate has kicked out and causes increased pressure that way on the esophagus or the pharynx. So diagnostic methods, the contrasted swallow study or the video fluoroscopic swallow study, barium swallow, that led the way in being able to diagnose these problems. While 41 patients underwent CT scan for diagnosis and 34 endoscopy. Plain radiograph and MRI were more rare in confirming a diagnosis of esophageal perforation, according to this paper. And in the repair method, they recommended otolaryngology or CT surgery, depending on where the esophageal perforation was. And 55% of their patients required a muscle flap bolstering for repair. 31 patients only required primary closure only, and then 12 were treated conservatively. So of patients who underwent repair, 12% of these patients suffered a form of complication. Most likely, the complication was related to infection, including pneumonia, mediastinitis, osteomyelitis, and sepsis. ARDS and recurrent laryngeal nerve damage were more rare. Oral intake on average was 30.2 days and median 15 days. It's kind of a bimodal peak, demonstrates kind of a bimodal peak again, where patients who have probably a less severe perforation that maybe primary closure can resume oral intake quicker, whereas a more robust repair needed with flap and whatnot require a longer period to receive NG tube feeds or gastrostomy tube feeds and esophageal rest. Each patient required about 1.5 attempts for to repair the esophagus, and the mortality in this paper was 4%, so a little bit less than the background that we found. Another paper that I want to present today was recently published in 2021, and it's basically it's a case series at a single institution at UCLA regarding these heterogeneous presentations of pharyngoesophageal diverticula occurring after cervical spine surgery. And I wanted to present this paper because they offer a little bit different repair method than what we see in our paper that I'll present last. So this is a 13-patient case series from 2000 to 2020 with the main idea to discuss pathophysiology, presentation types, and assessment and management algorithms. So they identified 4 different presentations for these presentation patterns for these patients. Type A, I guess, would be the most severe, is an esophageal perforation in exposed cervical hardware, where the barium contacts the instrumentation. So it's apparent on the esophagram that you can see the barium actually contacting the anterior cervical instrumentation, thus leading to a presumed diagnosis of esophageal perforation. And then type B is a diverticulum adjacent to the hardware without apparent barium contact, but then the scoping or endoscopic looking at in the esophageal lumen actually shows that there is a perforation present and the instrumentation can be viewed. And then type C is a diverticulum after history of cervical hardware removal or non-instrumented surgery. And there's just a diverticulum there without, and it ends in a blind sac. The type D is something they describe as an esophageal fistula. And these 3 patients all had either type A, type B, or type C's initially. So something to keep in mind. So here's an example of a type A where the barium swallow actually backs up and contacts the anterior cervical instrumentation. In the B panel, it shows after repair how the instrumentation has been removed anteriorly, and then also the diverticulum or the esophageal perforation in this case has been repaired. Type B is, once again, you see this diverticulum, which is an esophageal perforation, because as they show the scoping image, you can see the anterior instrumentation within the within the esophagus. Here's an example of a type C. So this is just a diverticulum after a patient had underwent spinal surgery. There's no instrumentation there. So I don't know the history of this patient, but you can see that where this asterisk denotes kind of the party wall of the diverticulum. And then, so this was treated with a CO2 laser to ablate this tissue in order to allow food to more smoothly pass through this area. So in their evaluation and management of a patient with pharyngoesophageal diverticulum and history of anterior spine surgery, they first ask the question, is hardware present? If the question's no, then they recommend a typical diverticulotomy that is performed for similar to a Zenker's diverticulum. And then they consider a partial epiglotticectomy for if the patient has significant follicular residue. Now, if the spinal hardware is present and the esophagoscopy shows exposed cervical hardware, then they have a staged surgical approach that they use, which is different than our approach, and I'll get into that in a second, where they go transcervical with hardware removal, perforation repair, and an SCM flap and gastrostomy placement. They follow that up with doing an endoscopic laser diverticulotomy, which is a part of this we did not perform. So to get to our paper, we present free tissue transfer for repair of chronic esophageal perforations. So we reviewed 5 patients at our institution who came in from an outside facility with complaints in their esophagus, and we'll get into that as well. And we reviewed basically our operative technique. So we had patients that ranged from 41 to 73 years old, three females, 2 males. 3 of our patients were active smokers, and the level of the defect ranged from the cervical esophagus to the hypopharynx. Now, 4 of our patients underwent a free flap from the vastus lateralis and 1 from the radial forearm. Now, the patient with the radial forearm free flap, Dr. Turner presented earlier, and this was the patient with the 11 by 5 centimeter defect. Now, all patients underwent a cricopharyngeal myotomy in order to prevent esophageal stenosis postoperatively. And then the length of stay ranged from 5 to 13 days, and time to regular oral diet was that bimodal peak I discussed earlier, where you have patients 15 to 17 days, and then 150 to 200 days postoperatively. All patients received gastrostomy, and only 3 patients received a tracheostomy. Of interest are the index surgery of index cervical spine surgery was 22 to 96 months prior to the patient's presentation to our institution. And this is a kind of unpublished data from that same set. Here's 5 patients. One of them never underwent repair because he refused. but I wanted to kind of point out some salient points from this. I think the initial BMI ranged from 20.5 to 29.8, and then the last recorded BMI or the BMI repair, a couple of our patients lost significant weight and then continued to lose weight after the last recorded BMI. These patients were all either current or former smokers, and then trauma was a prevalent indication for the initial surgery, whereas degenerative disease also equaled that. All these patients underwent multi-level fusions, including 2 patients undergoing a corpectomy, a C3 to 7 ACDF, a corpectomy plus ACDF. And then that time to diagnosis, I think, is something really to keep in mind. And this is something I think our primary care physician colleagues should be aware of. Patients presenting with dysphagia or dynaphagia or having recurrent abscesses in their neck, even if their anterior cervical spine surgery is very remote, esophageal perforation is something to consider. In our diagnostic method, typically for these patients, was either a scope or a barium swallow, and that's what we were able to kind of finalize the diagnosis with. So that kind of gives you our experience. So in conclusion, does the patient have history of anterior cervical hardware? Do they have weight loss, dysphagia, or neck and drainage? Think esophageal erosion and consider getting a barium swallow or consulting ENT to perform a scope to take a look at things. Here are my references.
Well, thank you very much, Matthew, for that. That was a comprehensive literature review, and it's interesting and important to know that Zenker's or diverticulum can also be a presentation of these patients. It's not just perforation. I know time is limited. Dr. Sunday, did you have anything to add with respect to the flap repair? I take it that conservative treatment is least likely to work. Direct repair is less likely to work, and most of these patients need some kind of flap, whether local or free, or local and free. Is that right?
Yeah, I agree. In these cases, in our hands as well. For the smaller ones, you can't. If a primary repair of the mucosa is possible, that's the best for the patient, certainly. But separating the dead space after these approaches is cool. You can almost esophagus kind of like a skin graft if you don't put anything vascular to supplement the healing of that injured, vitalized mucosa. I think anecdotally, the leak rates are much higher in our world. We kind of talk about obliterating dead space with vascularized tissue, and that's kind of the concept. If you dead space in an environment where you've had a mucosal injury, or you leave hardware immediately behind where you had an injury and just do a primary and lay it back down on the hardware, significant. The only other comment, it was interesting view on that, Dr. Helton. I think one of the differences, for instance, if you look at traditional Zenker's diverticular repair, multiple options, endoscopic stapler, endoscopic CO2, or just open approach. And the open approach is for young, arguably the best, because the longevity of the repair is the best. And in the traditional, all you're doing is myotomy and so what we do in all these cases is a myotomy below the diverticula. So essentially, with the primary surgery, we're taking care of the diverticula at the same time with having to, and just by doing a myotomy as you would with a open anchors. And so I think we're kind of technique differences, whereas they decided they rather stage it and went back second, which is perfectly acceptable. They had good results doing that. And I think the literature, it's a mixed bag of smaller cases, and there's so much, surgeon preference and surgeon that comes into this, and you kind of, just like anything else, have to know kind of what works in your hands, I think. Yeah,
that's great. Thank you. We've only got a few minutes left. Last question with Dr. Pate, and if anyone else wants to chime in. A screw that's backed out after your successful anterior cervical spine surgery, patient turns up and follow up 6 weeks or even later, and there is a screw that is prominent, and that is not what you wanted or expected or thought would happen. What do you do? Do you, after this talk, are you calling your ENT colleagues and planning a surgical repair, or what is your intrinsic algorithm, Dr. Pate?
No, not at all. I think you've got to go on the patient's presentation. If they have none of the signs or the symptoms that we spoke about, and the screw is not lost. You know, I've seen Professor Casper, I mean, literally have a screw eroded into the esophagus, and it was a missing screw. You know, so we've seen those. Those were where we didn't have the locking screws. They had to be bicortical fixation screws. But the patient is without symptoms, and the screw is just slightly backed out. It didn't get locked into the plate for some reason. Maybe it was at an angle. I'd probably follow them. I wouldn't do anything with them. Again, it's the patient presentation that determines the avenues that you will pursue. The other thing I'd like to point out and leave you with is that as surgeons, post-operative, we concentrate on the instrumentation, the so-called hardware, whether it's well-seated, fixed, loosening, back out. But we forget about those traps that I mentioned that are waiting for us as we approach the cervical spine. So never just look at an X-ray, and we hear it often with the cases we presented, was that the X-rays were okay. Well, the X-rays may be just fine, but think about the traps that you had to go through to get there. A high index of suspicion, and it's okay. We all have complications. We all have adverse events. So call for some help. It's fine. Just don't say the X-rays are fine. Have those anatomical eyes that W.W. King mentioned in 1895. You have to look beyond that which you're addressing.
Yeah, no, thank you very much. What a great point. Really, we're educated as to lowering our index of suspicion, maintaining our calm, being objective with respect to patient clinical status, and developing good rapport and relationships with our expert ENT colleagues that can help us when we need them. Thank you very much. Again, I'd like to thank everybody here on the panel. Thank you, Dr. Sunday. Thank you, Dr. Pate. Thank you to